Hello, back again. Let us start with this next module, National Vector-Borne Disease Control Program. We have learned many things in the malaria in the previous module. Now we are going to talk about National Vector-Borne Disease Control Program. First MCQ, we are very proud to be associated with this program because why? This is the first program of independent India. It is the oldest health program. It is the first health program of independent India way back in 1953, launched as National Malaria Control Program. So let us have a few words about the National Vector-Borne Disease Control Program, diagnosis and treatment in this module. National Vector-Borne Disease Control Program, MCQ number 1. How many diseases are covered under this program? 6 diseases. Which are those 6 diseases? We have malaria, dengue, kala azar, lymphatic filariasis, chikungunya, and Japanese encephalitis. So these are your 6 diseases. Next MCQ. All of the following diseases are mosquito-borne except which one? Kala azar is the only one which is a sandfly-borne. All other diseases are mosquito-borne except Kala azar, which is a sandfly-borne. Next MCQ. What are the targets of the program? The targets of the program are pertaining primarily to the malaria targets. Why? Because the mother program is actually a malaria program which came on, a lot of evolving happened, and then we came up to this National Vector-Borne Disease Control Program. So the targets you need to remember for your exam is that at the first level you need API. How much should be the API? API stands for annual parasitic incidence. It stands for annual parasitic incidence or parasite incidence. It should be less than 1 per 1,000. Next is, what is another target? Do we have another? Yes, it is ABER, that is annual blood examination rate. Annual blood examination rate, it should be more than 10%. Mind it, this is less than 1 and this one is more than 10. If you do a mistake, that is your problem. Please remember, I'm telling you the mistakes which you might do in the exam. API is less than 1, ABR is more than 10. Next MCQ. Next target, we are still on the targets, like third point that you need to remember for the targets. We have to control the spread and the death, that is control morbidity and mortality. Control the morbidity and mortality from what disease? Very important disease, that is dengue. Third point, we are still on the target. Third is to eliminate something. What do you want to eliminate under this program? We are primarily trying to eliminate Kala azar and lymphatic filariasis. Most of the things have already been done, and of course the remaining will also be done, and the Kala azar and lymphatic filariasis will be eliminated soon. So next is point number 3. Let us talk about the strategies under this whole big program, National Vector-Borne Disease Control Program. For a moment, think you are the director, National Vector-Borne Disease Program. Your office is at Shanti Marg in New Delhi. You want to stop malaria from happening, dengue and all these things from happening. How are you going to do it, that thing on earth, right? So that's what the problem is. So just pause the video right now and write it on a page that what are the activities you're going to do. You'll give them nets, you'll give them fish, you'll give them maybe insecticides, you'll do fumigation, and you will also need to take care of the patients also. So now, the first thing that we are going to talk, the strategies, primarily I'm going to talk in this module about the malaria strategies pertaining to malaria. So the first strategy that you will be talking is early diagnosis and prompt treatment. Early diagnosis and prompt treatment of malaria. First MCQ, how are you going to diagnose malaria? The diagnosis under the program for malaria is done at 3 levels. We can either have a blood smear examination or a slide making of the malaria parasite for the malarial parasite, or we can have a rapid diagnostic test. RDT stands for, or the rapid diagnostic kit. I might write it as RDT or RDK. Rapid diagnostic kit or a test. Or we might do serological test. All these are antigen or antibody based tests, or we might have clinical diagnosis. So of course, clinical diagnosis is not being evaluated under the program. We do have an option of RDTs, that is rapid diagnostic kit or the rapid diagnostic test to be used. And in fact, the most gold standard in India, the gold standard that we use for diagnosing of malaria in India is a blood smear examination. A couple of MCQs on blood smear examination. When we take the blood film, when we make the blood film for malarial parasite, when we make the blood film for malarial parasite, how many films we can make or how many smears we make? We make thick smear and thin smear. Thick smear is for identification of parasite, and thin smear is for identification or to find out what species is there. So to say parasite yes or no, thick film, and for thin film is for identification of the species. Next MCQ. How will you stain this thick film and the thin film? It is stained using JSB stain. We might also use GIMSA stain, but under the national program we are using JSB and GIMSA both, but JSB is what can be asked in your exam. What is a JSB stain? It stands for a Jaswant Singh Bhattacharya stain. So these are couple of MCQs which you might get on blood smear examination or RDK. RDK, I would also like to point out over here that when we talk of RDKs, there are certain approved areas where you can do the diagnosis of malaria using the RDKs or the RDT. That is only in the northeastern states. In the northeastern states, if a patient gets malaria, and if the RDT is done, we will, and if it is positive, we might say this is malaria. But if you are from Tamil Nadu, from Karnataka, from Gujarat, from Delhi, from anywhere else except the northeastern states, and if you get a RDT done and then you say that my RDT is positive, that is not considered as malaria. In the whole country, blood smear examination is the gold standard. That is the diagnostic, most sensitive and most specific test. Whereas in northeastern states, blood smear is of course there plus, and we can also do RDTs only in the northeastern states. If you have watched the module in screening of disease, we discussed there that if this is the table, right, for screening of disease, and if you move the prevalence like this, left or right, so if the prevalence increases, if the prevalence of any disease which increases, if the prevalence increases, what will happen to the false positivity? The false positivity will come down. The false positivity will come down. That is what is happening with RDK. It's not the RDT has become better in northeastern states. The RDT is still the same, but because the prevalence is super high and in those states, and that's the reason the false positivity, the chance of false positivity will decline. And because false positivity decline, the positive predictive value increases. And that's what is the understanding for approving rapid diagnostic kits in malaria. That is how you are going to integrate the whole understanding of epidemiology and biostats with national health programs and growth charts and mother and child health and demography. So anyways, let's get forward and let's talk about the next point, number 4. We will talk about the treatment strategies which are available under this program. So under the treatment strategies, whatever I'll be talking will be under the National Malaria Drug Policy 2014. It has not been yet updated on that, and that is what we are following till now. So for the treatment, we might have two types of infections. We might have, broadly speaking, Plasmodium vivax infection, or we might have a Plasmodium falciparum infection. The drug of choice for Plasmodium vivax infection is we are supposed to give chloroquine plus primaquine. Chloroquine plus primaquine. Chloroquine is given at the dose of 25 milligram per kg body weight. 25 milligram per kg body weight. MCQ, it is given over 3 days. It is given over 3 days. What do you mean by over 3 days? It is given as day 1, day 2 and day 3. On day 1, we give at the rate of 10 milligram per kg body weight. On day 2, it is again given at the rate of 10 milligram per kg body weight. On day 3, it is given at the rate of 5 milligram per kg body weight, 10, 10 and 5. 25 milligram, you can remember it for simplicity's sake, 25 milligram given over 3 days for chloroquine for Plasmodium vivax infection. In case we talk of the primaquine for Plasmodium vivax infection, the dose of primaquine is very easy to remember if you remember the dose of chloroquine. Chloroquine is 25, primaquine is 0.25. Chloroquine is 25, primaquine is 0.25 milligram per kg body weight, and it is given for 14 days. It is given for 14 days at the rate of 0.25. So please remember, everything is 25 in case of Plasmodium vivax. This is given for 14 days primaquine, and chloroquine is given only for 3 days. Now let us come to a little bit more dangerous type, that is the Plasmodium falciparum infection. If you talk about the Plasmodium falciparum infection, the drug of choice or the treatment that we give currently is ACT. ACT stands for artemisinin or the artemisinin derivatives combination therapy. Combination therapy. That is what is ACT. ACT can further be of two types. We can have ACT can further be of two types. We can have ACT-SP and ACT-AL. ACT-SP stands for sulfadoxine plus pyrimethamine plus artesunate. So in this we are having artesunate, which is a derivative of the artemether. On the other hand, ACT-AL will contain artemether plus lumefantrine. This artemether lumefantrine is abbreviated as ACT-AL. Mind you, it is abbreviated as ACT-AL. And on the other hand, the artesunate combination therapy, artemisinin based combination therapy with artesunate, sulfadoxine and pyrimethamine, it is abbreviated as ACT-SP. What is the difference between ACT-AL and ACT-SP? Please remember that ACT-SP will be given in all areas in India except the northeastern states. So northeastern states, what do we give? We give them ACT-AL. Certain reasons are there, that because there is very high prevalence of falciparum in northeastern states. And if you're giving the same ACT-SP, or if you're giving simple chloroquine, or if you're not giving anything, in those cases there is a chance of having chronicity with falciparum, or of course there is chance of having a resistance strains towards these drugs. So we might lose these drugs. We've already faced the burden of getting severe malaria back again when we lost chloroquine to the game. So now we don't want to lose this drug. So for northeastern states, we have a special category of drug, that is ACT-AL, which contains artemether plus lumefantrine. Please remember this for your exam. That is given only in the northeastern states. Now comes your MCQ now. MCQ is, how do you give this ACT? So first let me talk about the ACT-SP. First is, we are talking of the general India. What are the things that you need to do? So ACT-SP, you already know that S stands for sulfadoxine, P stands for pyrimethamine. So there is ACT-SP is given for 3 days. 3 days. How is it given? It is given on day 1, on day 2 and day 3. So what do we give on day 1, day 2, day 3? On day 1, we are giving artesunate plus sulfadoxine plus we are also giving the pyrimethamine. So we are giving all three together, artesunate, sulfadoxine and pyrimethamine. Day 2, we are giving only artesunate plus primaquine, plus we are giving primaquine. This is given as a single dose. We are giving primaquine single dose. When do we give it? On day 2. And on day 3, we are giving the same answer. We are giving them artesunate. So artesunate. Day 1 gets artesunate, sulfadoxine, pyrimethamine. Day 2 gets artesunate and pyrimaquine, and day 3 gets only artesunate. Next MCQ. Point number 5 is done. So point number 6. What is the dosage of all these artesunate combination therapy? If you talk about the dosage of artesunate combination therapy, we can have something called as the PIG-RU. What is a PIG-RU? P-Y G, R, that is red, W, that is white. So for white, I'm using black, because if I write white, then what will you write, right? Or what will you see? So it's PIG-RU. That's how I have remembered PIG-RU. That is P-Y-G-R-W. P stands for pink category, yellow category, G, green category, R, red category, W, white category. So for each of them, there are particular age groups. So what is this? This is age-based categories for treatment of Plasmodium falciparum infection. So these are age-based. These are not weight-based. Currently, we have the age-based categories. So in these age-based categories, we are going to give them artesunate, we will give them sulfadoxine, we will give them primaquine and pyrimethamine. So PQ stands for primaquine, okay? So PQ I'll discuss in the last because it is given only on single day. So what you have understood till now is that you are giving 3 days artesunate combination therapy and you are giving different drugs. So now I'm going to show you what is the dosage of those drugs based on this understanding, day 1, day 2, day 3. So for each day, artesunate can be given as, like, what is the dose? What is the dose of chloroquine? Chloroquine was 25. What is the dose of primaquine? Primaquine was 0.25. What is the dose of artesunate? Artesunate is also 25 because everything is 25 in malaria. So this is 25 milligrams. It is given as per day, artesunate. So it is easy now, 25 will double it up to 50, will double it up to 50, then 100, then 150 and then 200 milligrams per day. So all the doses will be milligram per day. All doses are milligram per day. So I don't need to repeat and rewrite every time. So it is 25, 50, 100, 150 and 200. I know that you might be getting a little bit panicky right now that why am I going so slow, but please understand these numbers won't make any sense to you. But there is a particular pattern to it. So if you want to understand that pattern, so you should stay with this. So I'm just trying to tell you that in the exam, it's one thing is there that you just memorize these numbers. Another thing is just understand this pattern. There is a pattern. So 25, 50, 100, 150 and 200. Next, let us talk about the sulfadoxine. Everything is 25, I told you. Now, in sulfadoxine, the dose, you just add 0 to the artesunate. So what does it become? Sulfadoxine will become, the pink category will become 250. You added 0 to it, right? Next is pyrimethamine. How do you calculate pyrimethamine? Just subtract it by 2. So answer will be 12.5. Now, yellow category. In yellow category, it is nothing but the double of the pink category. So it is double of the pink category. So 250 will become 500, 12.5 will become 25. Next, green category. Green category is nothing very special. It is a pink plus yellow category. That is 250 plus 500, 750. 12.5 plus 25, 37.5. Next is red category. Red category is very interesting. It is a double of the yellow category. It is double of the 2 times the yellow category. In practical also, we give them we don't have all the category tablets. Yellow category, we just give them double the dose. So that's how you should also remember it. What is the double dose? It is 1000 milligrams of sulfadoxine with pyrimethamine of 50 milligrams. Next is white category. White category is very interesting. It is the double of a green category. It is 2 times the green category. Green category is 750. So this will become 1500 and 37.5 will be 75 milligrams. Right? Very simple. Next is coming over to the primaquine. Primaquine, you tell me what is the dose of primaquine in this category? Pink category. Pink stands for baby. Baby stands for less than 1 year. In baby less than 1 year, do you think primaquine you will give? Answer is never give primaquine to infants because primaquine is contraindicated in case of infants. Primaquine is also contraindicated in case of G6PD deficiency. Primaquine is also contraindicated in case of pregnancy. So these are the contraindications for primaquine. So why do you want to give primaquine? No primaquine. Next is what is the dose in the yellow category? Primaquine is available in the market or with the government of India as 7.5 milligram base tablet. 7.5 is based on a 10 kg baby child. So 10 kg or a child or a baby or whatever you want to say. So it is based with the average weight of taking of 10 kg. At 1 to 4 years, taking an average of 2 years, let us say, if you take average of 2 years, the baby weight is doubling at what time? When the baby is born, in pediatrics you must have done, baby doubles at what time? 6 months. Baby trebles at 1 year. Baby quadruples at 2 years. So if you take an average baby of 2.8 or 3 kilograms, the baby is going to be roughly 10 kgs by 2 years. And that is what the average we are taking. So the weight of the baby would be 10 kgs and the tablet that we are giving is 7.5 milligrams single tablet. In green category, you give them 2 tablets, 4 tablets, 6 tablets of that 7.5, 7.5, 7.5. So what is the answer? 7.5 2 times, that is 15 milligrams of primaquine to the green category. And in the red category, 4 tablets, that means 30 milligrams of primaquine. And in the last white category, you're going to give 6 tablets. That means you are going to give them 30 and 15, 45 milligrams of primaquine. So this is what you have as the National Malaria Drug Policy. I know these numbers might be sounding so bad to you, but please remember, you should remember the pink category and you should remember the white category for your exams. Next is, let us also try to learn something about the ACTL-AL dosage system. I know it may get a little bit stuffy over here, but that's how it is. Please remember that in the ACT-SP, you had learned 5 categories, P, Y, G, R, W. In ACT-AL, we have only 4 categories. P stands for the, the pink category is absent. So first category is the yellow category. Then you have the green category. Then you have the red category. And the last you have is the white category. So P is absent, Y, G, R, W. Pig are you. So P, without the P, you have the ACT-AL. So this is the ACT-AL. So this is what you are studying right now. ACT-AL, first is differences that the pink is absent. Second difference is that this ACT-AL is predominantly based on the weight categorization. It is based on the weight categorization rather than in ACT-SP you had the age categorization. But still, there is certain age criteria as well. If you want to remember, you can. But mainly in your MCQ exam, they may ask you, in case somebody is asking you, they'll ask you only about the weight category. That is 5 to 14, 15 to 24, 25, 34 and more than 34 kilograms. If they ask you about the age, please remember that the first category is for less than 5 months of age till 3 years of age. Then 3 years to 8 years, 9 years to 14 years after 14 years of age. So that's how the age category is. Now in ACT-AL, we are giving artemether and lumefantrine. These are the 2 things you are giving. So artemether and lumefantrine, I don't need to tell you the exact dosages because that's not per kg body weight or that's not available as different tablets. In Government of India, it's very easy to understand. In Government of India, we have only 1 tablet. So that A tablet, that is the artemether, it contains 20 milligram of artemether. The L thing, that is the lumefantrine, it contains 120 milligrams of lumefantrine, that's all. So we have only 1 tablet containing 20 and 120. So now to yellow category, you give them 1 tablet, 2 tablet, 3 tablet, 4 tablet, end of the protocol. And these all tablets are given as BD dose and given for continuous for 3 days. That's what you have already done, right? So it is given as BD dose. So an adult person like me or like you, in case somebody, unfortunately, fingers crossed, gets malaria, that also falciparum malaria, and that also in northeastern states, what is the drug schedule we are going to get? We are going to get a white category. We are going to have 4 tablets in the morning, 4 tablets in the evening of artemether and lumefantrine, fixed dose, single combination. That's all. So that's what you need to remember. It's very easy. 1, 2, 3, 4 tablets you're going to take. Each tablet is going to contain 20 artemether and 120 lumefantrine. And the number of tablets you're going to consume at a single dose is what is there, 1, 2, 3, 4. And you have to do it in BD doses. That completes your treatment modality for ACT, SP and AL. One point you need to remember that ACT-SP, it is not given in first trimester of pregnancy. It is not given in first trimester of pregnancy, and it is also not given to age less than 5 months. On the other hand, the ACT-AL is again not given to age to first trimester, of course, first trimester pregnancy. And it is not given to weight less than 5 kgs and age less than 5 months. So please remember, these are certain things that frequently are crossing our boards on the social media platform, and very frequently I get these questions, and that's what is important for you to remember. Next is, let us come to the next section of understanding this National Vector-Borne Disease Program. We will talk about the treatment of malaria in special situations. in special situations. What are the special situation? Number one, you can talk about is malaria in case of pregnancy. So that is malaria in case of pregnancy. So now unfortunately the female is having pregnancy and she's also got a malaria infection. So in those cases, what is the protocol? The protocol number one is that in the first trimester, the drug of choice is quinine. In the first trimester, the drug of choice is quinine. It is given at the dose of 10 milligram per kg body weight, TDS dose, 3 times daily dose. This has to be continued for 7 days. In the first trimester. Problem with quinine is that many females may land up into hypoglycemia with this. So the nutrition component is important for us as program managers, that we need to tell the people that they should be taken care of any case of hypoglycemia, caution with hypoglycemia. In the second trimester or in the third trimester, in the second or the third trimester, please remember the ACT with ASP, SP and AL can be given. Now, mind you, again, a very frequently question which drops me on the board is that, sir, you're saying that ACT is contraindicated in pregnancy and in second trimester ACT is given. What do you want to say at the end of the day? Please remember in the previous page where I told you that ACT SP is contraindicated in the first trimester, I'm still saying that ACT, SP and AL are contraindicated in the first trimester. But when I teach you severe malaria over there, I will say that single drug therapy with artesunate can be given. It means that artesunate combination therapy, which includes the S and the P or the lumefantrine, these are contraindicated. Are we understanding this? That ACT, SP, in that the SP model, that is contraindicated in pregnancy in all the pregnancies. But artesunate can be given, right? So please remember that in pregnancy, first trimester, we are not giving ACT, SP and ACT, AL. Very frequently, we get a question on this. So that's a small understanding that you should be having. Next is in case of severe malaria. In severe malaria, what are we going to do? Now, severe malaria, that means black water fever, cerebral malaria, or any case of danger signs are there. In those cases, what are we going to do? Of course, the first thing is you need to admit the patient. After admitting, what are you going to do for the initial at least 48 hours. So this is at least 48 hours. What are we going to do? And after that, what is the follow-up which is to be taken up? After that, what is the follow-up? So there are different protocols. The first protocol that you just need to know the names. The first protocol is IV quinine. We can handle the situation of danger malaria or severe malaria with IV quinine. It is given as intravenous or we can give it as IM also in divided doses. It is given at the rate of 20 milligram per kg body weight. We will give it at frequent intervals. So that is quinine. Next is once this 48-hour period is done with a loading dose of 20 and then there is a maintenance dose of 10 and so on, it just decreases. But there are a couple of other considerations also. It will of course depends on the case to case basis, right? In case this patient is all okay for 48 hours, then we switch over to the follow-up regime. In the follow-up, we can give, in case you are giving quinine before, you should give quinine again. Quinine again is given at the rate of 10 milligram now as TDS dose. 10 milligram is given as TDS dose, plus we are going to give to the patient doxycycline or we can give clindamycin. Clindamycin will be given in cases of pregnancy or in case the child is less than 8 years of age. Why? Because doxycycline is contraindicated. So that is your schedule number 1. That means you need to give we can give quinine plus doxy and or clinda. In the next schedule, in cases of severe malaria, we can also give artesunate as single therapy. Artesunate as single therapy. Otherwise, artesunate single therapy is banned in India. Only in case of severe malaria, we can give artesunate at the dose of 2.4 milligram per kg body weight. It is again given as IV or it is again given as IM. It is given as 12 hourly. You give it on 0 dose and then you have at 12 hours and then you again repeat it after 12 hours. So it is given every 12 hourly. And after this, we will do a follow-up with ACT. Has to be given ACT SP or the ACT AL, whatever the case is, for 3 days. So you can handle severe malaria with artesunate. We can also handle the severe malaria with artemether. RT-mether, or we can also handle with RT-ether. RT-ether. So RT-ether has some consideration for children. It is usually avoided age less than 5 to 6 years, but RT-mether can be given, RT-sunate can be given. Of course, the most commonly used regime in case of severe malaria is either RT-sunate or we are giving IV quinine. So these are the two things. In either of the cases, the follow-up has to be ACT-SP or ACT-AL to be given for at least 3 more days. So that's a simple protocol that you have for severe malaria. Next is what happens in case you have mixed infection. That means what the problem that the patient is having. Third scenario I'm going to talk is mixed infection. What the patient scenario is there, that either you do a rapid diagnostic kit or you do a peripheral blood smear. You can either get a Plasmodium vivax or you get a Plasmodium falciparum. So in Plasmodium vivax, you already know that we give chloroquine plus primaquine for 14 days. Chloroquine for 3 days, chloroquine for 3 days and primaquine for 14 days. You already know this 25 and 0.25. In case it is Plasmodium falciparum, what is the drug you're giving? You're giving artemisinin based combination therapy. It should be SP or AL depending on the northeastern states or the normal states. Plus you are also giving them, like, it's not plus, you all already know primaquine is a part of the ACT-SP or the ACT-AL, right? It's given as a single dose. This is given at the rate of 0.75 milligrams as a single dose, because like 3 days, instead of 3 days, you're giving it as a single dose, right? So 0.75 milligram per kg body weight, you're giving it as a single dose on day 2. You already know this. On day 2, you are giving primaquine. Next is, in cases of mixed infection, what to do? In case of mixed infection, we are supposed to give to the patient ACT. This ACT can be SP or AL depending on the location of that person. Plus, we are going to give primaquine at the rate of 0.25 milligram per kg body weight given for 14 days. Why do you want to give primaquine? Because it's a mixed infection. You want to take care of the vivax as well, who's going to have a pre-erythrocytic or a pre-hepatic stage for a longer duration, right? So vivax considerably has a longer duration life cycle, and that's the reason you're going to extend primaquine for a couple of more days. That is primaquine to be given for 14 days in case of mixed infection with ACT. Right, so that's the gross difference between the primaquine, between the vivax, between the falciparum and with the mixed infection. The next is point number 4. Let us come to some of the general points for you to remember for your MCQ exams under this treatment and diagnostic. A lot of miscellaneous points can come. So I've just gathered all the list of the points and I'm going to discuss with you right now. First is what will happen in case of vomiting to the patient. So in case of vomiting to the patient happens, the patient vomits. So of course the drug comes out. So in case the drug comes out, you should give the new drug. MCQ over here, that's what we tell the people who are handling malaria, the malaria workers and people, ANMs or the doctors who are going to handle malaria cases in the field, that in case the patient vomits, you should discard that packet of malaria tablets, use a new tablet packet. So repeat dose from new blister. Why? Because that will avoid any kind of confusion. Next is what will you do in case of northeastern states? Please remember that in northeastern states, 2-3 MCQs can come. What is the diagnostic test of choice? Diagnostic test of choice, when they ask, it is always a blood smear examination. But in northeastern states, as already discussed with you, that the rapid diagnostic kits are also approved. They are also approved for malaria diagnosis only in the northeastern states. Rapid diagnostic kits can be monovalent, can be bivalent, only falciparum or falciparum and vivax both. So either of the kits can be used. It's not that only monovalent is allowed or bivalent is allowed. Both the kits can be used. Both are approved, but only in northeastern states. Another MCQ frequently comes over northeastern states. What is the drug? I think this we have done a lot, that the ACT-AL is used. A stands for RT, A stands for RT-mether, and L stands for lumefantrine, and there is a single tablet which is 20 milligram of RT-mether, 120 milligram of lumefantrine, which is taken in dose of 1, 2, 3, 4. We already discussed that. Next, point number 3, all cases of fever, all fever cases in urban or in rural, you should always do, all fever cases either in urban or in rural, you should always do a microscopy test, that is what is a smear examination. All fever cases, that is mandate in India. Any case of fever should get a malaria test done. Fourth point, do we give chloroquine as blanket treatment? Answer is 2012. We stopped chloroquine. Chloroquine is to be stopped as presumptive treatment. Presumptive treatment. Please remember that presumptive treatment, earlier that person will go to the houses, malaria worker, and ask, do you have fever, yes or no, and give them 4 tablets of chloroquine. This phenomena of giving chloroquine to every case of fever led to increase in the drug resistance, and we lost the chloroquine drug, and we saw resurgence of malaria. India has faced a lot of burnt hands with malaria, that at one point you are on very big level, you have a lot of malaria, and within 5-7 years we decreased malaria from 80% to 40%, 50% malaria prevalence was cut down. And then we lost the drug, we came back again. And that is the reason. Do you know who discovered artemisinin? Artemisinin or the artemether derivatives were discovered. Artemisinin or the artesunate combination therapy. We are very thankful to a Chinese doctor. Her name is Yo Tu. It's so easy to remember. It's like you and Tu. Tu is Hindi for you, right? So that the name of the Chinese doctor, madam, is Yo Tu. She discovered artemisinin way back in 1972. And if you any day think that getting a Nobel Prize is easy task, then look at Yo Tu. She discovered in 1972 and she won the Nobel Prize for malaria discovery in 2015. You have to wait for some time. In case she was way back then, she was a middle age or a young female, and today she's fairly on the elderly side, we would say. And that's the use of this medicine. And in case artemisinin was not given to the world, then the whole world would have been in problem, because we did not have a malaria treatment, and we lost the drug to chloroquine to the malaria. So there would have been resurgence. Then we would have been talking about COVID and malaria a lot. So we are thankful to these people who have discovered these. Anyways, coming back, please remember that chloroquine has been stopped way back in 2012. Categorically, technically for your MCQ, you can remember it as 2014 we stopped it, but under the program we had stopped it way back in 2012. Last point to discuss before we close off this module is point number 5 about the in case of treatment failures. In case of treatment failure, what are you going to do, or what is a treatment failure? In case of treatment failure, we have to change the drug, or we refer to the patient to the specialist, or we use alternate drugs. That's what you change the drug, or you refer to the alternate. So the treatment failure can broadly be of 2 types. We can have an early treatment failure, or we can have a late treatment failure. The early treatment failure means there is danger signs persisting, either on day 1 or day 2 or day 3, but any day the danger signs is persisting. Or in case there is parasitemia, which is persisting on day 2, which is more than the day 0. More number of parasites on day 2 compared to day 0. Or in case there is parasitemia on day 3 also with fever. That means your fever is not going off. So there are 2-3 criteria. Any criteria that is called as early treatment failure, but the point to be noted is it is early everywhere. I have talked of day 1, day 2, day 3 only. Late means that it has to be after day 3. Late treatment failure can be of 2 types. We can have a late clinical failure, or we can have a late parasitological failure. The late clinical failure, or the LCF or the LPF. The LCF is clinical failure. That means there is presence of danger signs. Plus there has to be presence of parasitemia. So it is danger signs and parasitemia. Both are present. When are they present? They are not early. They are late, day 4 till day 28. So sometimes the parasitemia goes and it comes back. That is a late treatment failure or a late parasitological failure. The parasitological failure is nothing without a danger signs. Like if the danger signs are present, that would be categorized under clinical failure. In late parasitological failure, we sometimes see only parasitemia from day 7 till day 28. Anytime if we get back only parasitemia without any danger signs in the patient, that would be only a parasitological failure. So that means technically you have done early and late signs. Early signs could be because of the danger signs, parasites, or with fever with parasites. Late can be broadly late clinical failure or late parasitological failure. Clinical failure means the danger signs plus parasitemia, and parasitological means only parasitemia. So with that, I think we have completed most of your questions which can ever be asked. Or this is the limit. I have discussed with you the whole national malaria drug policy, and these are the very frequently asked some things here and there, because just try to imagine that it's a race. This competitive exam, it's a race, and I don't know what MCQs you're getting it. So with that, I would like to thank you so much for watching this module. In the next module, we are going to talk much in detail about the organization, about the other strategies, also about the vector control and so many things in National Vector-Borne Disease Control Malaria Program, or the National Vector-Borne Disease Control Program.